So in today's video we will be actually talking about the chronic liver cell disease. Okay. So this is actually a case based on the chronic liver cell disease. So it goes as a 50-year-old man consults his general practitioner with a 5-month history of weight loss of 8 kilograms, and for 1 month he has noted swelling of the ankles and abdomen. From the age of 18 he has smoked 9 to 10 cigarettes daily and drunk 15 to 20 units of alcohol per week. He now lives alone as his wife left him 1 to 2 years ago. So that is the case. Okay. And before we actually move on to the actual discussion based on this case scenario, we will actually talk about ascites a bit. So there are actually two types of ascites. So one is high serum ascites, albumin gradient, where the albumin content or concentration is more than 11 grams per deciliter. So the causes for this actually could be due to portal hypertension, hepatic outflow obstruction, Budd-Chiari syndrome, and cardiac ascites. And there could be there's another type called the low serum ascites albumin gradient, where the albumin concentration is less than 11 grams per deciliter. So the causes are peritoneal tuberculosis and pancreatitis, nephrotic syndrome, and peritoneal carcinomatosis. So now we talked a little bit about ascites. So now we will actually move on to if a patient comes with a presentation like this, or a presenting complaint like this, how are we going to approach, how are we going to take the history, what are the things that we should actually include in the history as well. So usually if a patient is having cirrhosis or chronic liver cell disease, they would usually complain of, they will usually present with edema, either jaundice or complications of cirrhosis like hematemesis, and we will talk about the complications a bit more. And we will obviously have to inquire about the decompensated features of cirrhosis as well, such as portal hypertension and ascites, variceal bleeding, and jaundice. And we will obviously have to, in the history, we will have to ask about the etiological factors as well, because we have to find out the exact cause for this chronic liver cell disease that the patient is having. So we would obviously have to take an alcohol history if it is a male, and we can ask about the infections, certain infections like hepatitis B and C, which can lead to chronic liver cell disease. So we can ask about any IV drug abuse, blood transfusions, and then it could be due to autoimmune diseases as well, such as the chronic liver cell disease itself can be due to a autoimmune disease. So we can ask about any associated other autoimmune diseases like vitiligo and thyroid diseases, like that. And if the patient is having non-alcoholic steatohepatitis, that could also be a cause for chronic liver cell disease. So we can ask about diabetes, obesity, and all that. And if the cause for chronic liver cell disease is certain inherited diseases or certain genetic diseases such as hemochromatosis and Wilson's disease, you can ask for those features as well. And then we have to ask the patient, or we have to inquire about the complications of cirrhosis as well, because that is actually important in the further treatment as well as the investigations that we are about to perform in this patient, right? So the complications of cirrhosis, the main complications are there is portal hypertension, right? So they will actually complain of hematemesis and gastropathy, splenomegaly features, those things we have to ask about. And then ascites is one of the complications, and it is usually due to the sodium and water retention, and also renin, angiotensin, aldosterone system activation, and could also be due to the transudation, due to the reduced oncotic pressure, right? Because there will be less production of protein in the liver, and which can lead to this transudation process. And this ascites can ultimately lead to spontaneous bacterial peritonitis as well, because the acidic fluid can act as a culture medium for this bacteria. And another complication is porosystemic encephalopathy, right? This is usually due to spontaneous shunting of toxic products, right, into the brain, right? This condition can be precipitated by certain factors like infections, diuretics, constipation, benzodiazepines, like that. And usually they will present with features like inverted sleep pattern and drowsiness, hepatic flaps, and disorientation and coma. And another complication is hepatorenal syndrome, and there are other complications as well, such as hepatopulmonary syndrome, primary hepatocellular carcinomas, and bleeding diseases. That is due to the coagulopathy. And in the history, we also have to consider certain differential diagnoses, as well as at the same time we have to exclude those differential diagnoses, because we have to ultimately come into a definitive diagnosis at the end of history taking. If we have any doubts, we can do the relevant investigations to confirm the diagnosis. So the differential diagnosis for a patient presenting with these sort of clinical features, we could take cirrhosis obviously, and then it could be due to congestive cardiac failure if the patient is presenting with edema, and then nephrotic syndrome, malabsorption syndromes, and hypothyroidism. All these conditions can cause edema, right? So those are the differential diagnoses that you have to consider if a patient presents with clinical features of chronic liver cell disease. So those are the factors, or those are the things basically that you have to include in a history, and other than that you obviously have to take a detailed history from the patient. So during the examination, we obviously have to, in the general examination, we have to look for certain clinical signs such as icterus, right, wasted thin limbs, loss of body hair, spider nevi, and palm erythema, gynecomastia, Dupuytren's contracture, testicular atrophy, and leukonychia, right? So those things you have to look for. And then in the abdominal examination, you have to look for a distended abdomen due to ascites obviously, and then caput medusae, splenomegaly, hepatomegaly, and then hepatic bruise on auscultation, and then cardiac failure signs, because we have to exclude that, and then basal fine crepitations due to cardiac failure, and then hepatic encephalopathy signs such as drowsiness, hepatic flaps, confusion, apraxia, those things. So these are the specific things that you have to look for. Other than that, you obviously have to do look for other clinical signs as well. So what are the investigations that we have to perform in this patient if a patient presents with chronic liver cell disease? So we obviously have to do the liver function tests, and then we have to do a full blood count, right, to see the platelet counts and those things, and then serum electrolytes, serum creatinine, because hepatorenal syndrome can actually deteriorate the renal function, so that you have to check. And then we have to do upper GI endoscopy if the patient is having any signs of variceal bleeding, esophageal variceal bleeding. Then we would actually do upper GI endoscopy to take prophylactic measures such as banding, stereotherapy, those things. And then to find the etiology, we can do certain investigations such as we can do serum alpha fit protein, right, which is elevated in hepatocellular carcinomas, and then in primary biliary cirrhosis we can look for ANCA, and those things we have to look for. And then in Wilson's disease we can look for ceruloplasmin and serum copper. And so ideally cirrhosis can be confirmed by liver biopsy, but it is not actually necessary, because the clinical features itself, clinical features can actually confirm the diagnosis as well. And then so those are the investigations that we have to do. And then when we talk about the treatment, obviously as in the general treatment, or so we can actually give advice to the patient to abstain from alcohol. And then if the patient is having viral hepatitis, so the cause for the chronic liver cell disease is viral hepatitis, we can give antiviral agents. And if the patient is having hemochromatosis, we can do venous extraction, that is the treatment of choice for that. And then we can if the patient is having any sort of bleeding disorders, we can correct that as well. And then we have to treat the complications. So if the patient is having hepatic encephalopathy, we obviously have to take an ABC approach. And if the patient is having seizure, that is, and we obviously have to give antibiotics such as metronidazole or rifaximin, right, to prevent any sort of infection, which can actually precipitate hepatic encephalopathy. And then we can give lactulose or enemas, right, to reduce the gut bacteria as well as to reduce the protein load as well. And there is this agent called Lola we can give to convert the toxic ammonia into non-toxic agent. And then we can give IV mannitol if the patient is having cerebral edema. And then we obviously have to monitor the patient with GCS, urine output, fasting blood sugar, and serum electrolytes, because and then if the patient is having ascites, so these are the treatment options. So we have to restrict salt in the diet, because it can actually worsen ascites, right? And we can give certain diuretic agents like spironolactone is given first, 25 milligrams twice daily. Then we can give furosemide 40 milligrams twice daily. And then we obviously have to monitor the patient as well with we have to measure the urine output, and then abdominal girth, and the serum creatinine and serum electrolytes. And then if the patient is not responding to that treatment, we can actually do a paracentesis, therapeutic paracentesis. Usually we remove 5 liters of ascitic fluid, and then we have to add 8 grams of 20% albumin for each 1 liter removed. And then we can actually, if the patient is not responding to that either, we can go for a transjugular intrahepatic porosystemic shunt. And if the patient happens to develop spontaneous bacterial peritonitis, there are certain investigations to confirm that as well. So we can do a diagnostic ascitic tap, right? And then we have to send the sample for a full report, culture, protein, gram stain. And if the white blood cell count is more than 500 or the neutrophils are more than 250, then we can actually confirm the diagnosis of spontaneous bacterial peritonitis. And then the treatment would be to give the patient IV antibiotics. Preferably we can give ceftriaxone or cefataxone. And if the patient is having hepatocellular carcinoma as a complication of chronic liver cell disease, and if the size of that tumor or size of that lesion is less than 2 centimeters, we can actually go for a conservative treatment. If it is more than 2 centimeters, then we will obviously have to go for a surgical option, or chemoablation, radioablation, or we can do a local resection, lobectomy, or we can actually do the liver transplantation, right? And if the patient is having variceal hemorrhage as a complication, then we obviously have to take a take an ABC approach, right? We have to monitor the patient's pulse rate, right, blood pressure, GC score, and all that, and then we have to gain IV access, and then we have to take blood for certain investigations, and then we give the patient IV fluids, IV crystalloids. If blood is available, we can start the patient on we can give blood to the patient, and then we obviously have to give vasoconstrictors as well, such as IV terlipressin 2 mg 6 hours a week, or we can give octreotide infusion 250 mg hourly. And then after providing the patient with those drugs, we obviously have to arrange an urgent upper GI endoscopy for the definitive treatment, that is banding or sclerotherapy. If the patient is not responding to that, then we have to go for the Sengstaken Blakemore tube, for where we keep that for 12 hours or so. And if there is rebleeding, then we obviously have to repeat the upper GI endoscopy and then do the banding or the sclerotherapy. And then if the patient is not responding to that either, we can actually go for the TIPS or emergency esophagectomy. And as a prophylactic measure, we obviously give these patients beta blockers like propranolol. So during the follow-up of this patient, right, we have to do certain investigations. So 3 monthly we do liver function tests, prothrombin time, full blood count, serum creatinine and serum electrolytes, and then 6 monthly we have to do the ultrasound abdomen alpha fetoprotein to check whether the patient is having hepatocellular carcinoma, and then annually we have to do upper GI endoscopy to detect variceal bleeding or so those are the main things, or the key factors that you have to remember when you're taking a history from a patient with a patient presenting with chronic liver cell disease. So we obviously have to keep in mind the differential diagnosis, and then we have to exclude them then and there. And then in the history we talked about what are the things that we have to ask from the patient, right? We have to take a detailed history. I mentioned the important things that you have to ask from the patient, and then after taking the history we have to do examination, and then we go for the investigations, relevant investigations, to confirm the diagnosis or to detect complications or to find the etiology, and then we actually treat the patient's complications, and then we advise the patient, and then we do the follow-up of this patient after treating the acute condition. So hope you found this video helpful. Thank you for joining.